Hey folks, welcome to Epicure's clinical webinar. We'll just get started in a few minutes as folks enter the room. Hey everybody, thank you for joining us today to hear Dr. Megan Reel discuss Psychogastroenterology and the application and use of brain-gut therapies. For those of you who are new to Epicure's clinical webinar series, I did want to take a moment to introduce myself and to introduce Epicure. So my name is Melanie Klesse, and I'm a registered dietitian working here at Epicure. I also see some GI patients myself at Nutrition Energy, which is a private practice here in New York City. Epicure is a healthcare company that provides food as medicine in a really practical way. So we deliver low FODMAP and gluten-free, fully prepared meals to people managing digestive disorders. I have the privilege of building our Partners in Health clinical community of registered dietitians, gastroenterologists, primary care physicians, and other practitioners who see our meals as a resource for their patients and to support them in improving education and adherence to the low FODMAP diet. I did just want to mention before we get started here for our registered dietitians on the line that we will be at the Food and Nutrition Conference this year. We are hosting a cocktail hour event on Saturday night that you are all invited to. We will also have a booth in the Healthy Gut Pavilion where we'll be sampling our infamous energy bites and other goodies throughout the conference. And I'll be sending out further details about this in my follow-up after the webinar to all of the registrants. So before we get started, just a little housekeeping. You all have been placed on mute to ensure that our speaker is audible tonight, but please send any questions through the Q&A function in your Zoom panel at the bottom of your screen. I'll be addressing them to Megan at the end of the presentation. Also, I'll be sending out the webinar recording and the CPE certificate for continuing education credit after the webinar tonight. Now, without further ado, I would love to introduce Dr. Reel. I'm so thrilled to have Dr. Reel with us today to discuss this compelling topic. Dr. Megan Reel is a GI psychologist who specializes in psychogastroenterology and anxiety-related disorders. She is the clinical director of the GI Behavioral Health Program at the University of Michigan, offering comprehensive treatment options for patients in the GI department. The GI Behavioral Health Program also offers state-of-the-art GI psychology training for mental health professionals. Dr. Reel strives to work from a collaborative perspective with treatment focused on improving one's quality of life, decreasing the frequency and intensity of medical symptoms, establishing healthy stress management tools, and improving coping skills. Her approach relies on principles of cognitive behavioral therapy to design unique and flexible treatment plans tailored to the individual. Dr. Reel's clinical research focuses on the delivery of GI behavioral health treatment for patients with disorders of the gut-brain and IBD. Dr. Reel is the co-chair for the Rome Foundation Psychogastroenterology Education and Training Committee, participates on 2 national committees pertaining to the psychosocial aspects of IBD with the Crohn's and Colitis Foundation, and sits on the membership and mentorship committee with the American Neurogastroenterology and Motility Society. Thanks so much for being with us today, Megan. I'll let you take it over from here and I'll just pass over the controls to you.
Okay, thank you for that lovely introduction. I'm so excited to be talking with everybody tonight. Let me get up and running here. There we go.
All right, you're all set.
Thank you. I am so excited tonight to talk about psychogastroenterology and really have the opportunity to talk a little bit about the brain-gut connection and how different psychological interventions can be very helpful in the management of these difficult to treat digestive disorders and diseases. So I'm lucky to work at the University of Michigan in our gastroenterology department, and I do not have any disclosures. But in our department, we really take a multidisciplinary approach because we really recognize that chronic digestive diseases have a substantial burden, not just on our healthcare system, but also psychosocially. And patients describe these difficulties in a wide range of their lives. And we've learned through research and also just in our daily workings with these patients that the disease severity and symptom severity ends up costing our healthcare system billions of dollars. And over the years, we've recognized that there are high comorbidities of psychiatric diagnoses like anxiety and depression. And so one's ability to cope and have resiliency can then impact the level and severity of burden. And so one of my jobs as a GI psychologist is to help patients better cope with their symptoms, as well as to develop different strategies to manage symptoms and really work toward improving their quality of life. So as we talk tonight, I'm going to give a little bit of background on kind of the current state of what we know about digestive diseases and the workings of the brain and the gut, and then jump into some of the interventions that I have the opportunity to work with patients on a daily basis. So we know that these diagnoses are very prevalent, particularly in the functional bowel sphere. And these diagnoses are traditionally known as functional gastrointestinal disorders. But more recently, the Rome Foundation, which is really the governing body over diagnosis and treatment for these common functional bowel problems, we've now changed the language, and we're calling these diagnoses disorders of gut-brain interaction. So where you would have, and you'll still see functional gastrointestinal disorder language, but we're really transitioning into this new kind of interpretation of that these disorders are so strongly tied to what's going on between the brain and the gut that we've relabeled them. So some of the symptoms that both gastroenterologists, dietitians, and psychologists are seeing commonly in these patients are abdominal pain, bloating, constipation, diarrhea, incontinence, regurgitation, dyspeptic symptoms, so really spanning from the esophagus down all the way to the rectum. And different diagnoses from a functional perspective that I treat are irritable bowel syndrome, functional dyspepsia, functional constipation, diarrhea, fecal incontinence, GERD, and functional dysphagia. The majority of my talk tonight is going to be focused on kind of IBS and these disorders of gut-brain interaction. But when it comes to treatment planning, a lot of these interventions that I'll be talking about are very applicable to inflammatory bowel disease and some of the other GI diagnoses that I might not mention. So I just want to make you aware of that many of these interventions have been utilized in the IBD world as well. So when we're starting to conceptualize the brain and the gut and the role of everything in between, there's a biopsychosocial model that can be very helpful in recognizing when patients come to us and they're saying, you know, what is going on with this diagnosis, and why I don't know how it started or where it started, but it is overwhelming and it is kind of taking over my life. It can be really helpful to provide patients with psychoeducation. And this biopsychosocial model can really help patients to understand that certainly their diagnosis is multifactorial and that there could be a genetic factor that led to their current symptoms and diagnosis. But oftentimes it's a kind of combination of psychological factors, this disturbance in brain-gut dysregulation and the brain-gut axis. And then there are environmental stressors that can tax the digestive tract, such as infection, use of antibiotics, and diet. And sometimes patients will say, yes, I've been having these symptoms since I was young, and I had a great deal of antibiotic exposure to my gut, but I didn't have the severity of symptoms that I have as an adult. And so then we can also start to look at some of these other factors. And certainly there's a great deal of literature looking at the impact of early life trauma and stress on patients with disorders of gut-brain interaction, having higher prevalences of these diagnoses. So obviously the role of our psychological makeup is important as well. So this biopsychosocial model also certainly kind of illustrates the role that early life stress plays. And this is also a model that Rome Foundation has adopted as well. So we've all heard this terminology, trusting your gut. We've probably also all found and experienced those butterflies in our stomach. And maybe you've even heard about the gut and the digestive tract as the little brain or the second brain. And it really is true. And what contributes to this is our enteric nervous system. And the ENS, their enteric nervous system, is really these two thin layers, but it's made up of hundreds of millions of nerve cells that line your gastrointestinal tract. Again, kind of ranging from our mouth all the way down to our rectum. And these nerve endings are sending signals back and forth between the gut and the brain constantly. And this is what creates then this gut-brain axis and a bidirectional communication pathway that, again, can be really helpful to provide patients with information on, because sometimes having this multi kind of biopsychosocial perspective and description of these very difficult to control symptoms can be so helpful. And also many of these patients, especially in the disorder of gut-brain interaction kind of makeup, they've had extensive workups of symptoms. And oftentimes it feels quite invasive to be having symptoms of IBS, diarrhea, constipation, abdominal pain, anxiety that goes along with that. You've had physical workups by maybe a primary care doctor, a gastroenterologist. You've undergone manometry, anorectal manometry, diaphragmatic, colonoscopies, endoscopies, all the oscopies, and then to be told that really from a medical workup perspective, there's nothing going on. And that language can be extremely impactful for patients. So the worst thing you can tell an IBS patient is that this is in your head. And because it doesn't feel validating, and it feels as though they're making up their symptoms. And when we provide patients with education on the gut-brain axis, it starts to make sense, because it's very difficult to have a medical workup that shows that there are dysregulations in your HPA axis or your limbic system or the autonomic nervous system. We don't have tests that get that specific for a patient in our general population. But being able to describe some of the factors that impact our brain-gut interaction can be extremely helpful. So I put a star next to a table that's really helpful in determining some of these factors, and then also the pathway to which we can provide patients with care. So again, this is going to focus in a little bit more on the IBS patient. And the stars are some of the areas that I talk with patients about. So disturbance and motility, even providing patients with suggestions about their motility being fast or slow, and the way in which the brain gut can impact that. Visceral hypersensitivity, that goes back to the ENS system, where those nerves are constantly communicating and can send pain very quickly up to the brain, and the brain interprets that pain. Also, the altered processing of those visceral signals. The psychological disturbances are kind of a no-brainer for why a psychologist would be working with a patient with IBS. And I'm going to talk a lot about kind of that role and how we apply these psychological principles. But what we know is that anxiety and depression and stress are prevalent in our population of IBS patients. And as I said, the early life stress can certainly alter the makeup of our gut microbiota. And so sometimes patients that have a history of trauma that maybe they've identified and treated in a general mental health perspective, and they feel like it's behind them. Sometimes in clinic with them, I will have to have conversations about still how the role of that early life stress or that trauma could be impacting their current gut function. All is not lost, though, because these patients can still have wonderful outcomes when it comes to working with a behavioral specialist. So when it comes to the prevalence rates of some of these mood symptoms in our IBS population, these numbers are somewhat staggering, whereas in the general population, these numbers are a bit less. So in patients with IBS that have symptoms of anxiety, it's about 39%, and anxiety disorders are at about 23% of our IBS population. Now with depression, the symptoms, again, so this doesn't mean that you meet criteria for major depressive disorders, but yet you experience occasional or more frequent symptoms that it could include sadness, frustration, difficulty sleeping, hopelessness. That prevalence is close to 29%. And those meeting criteria for disorders such as major depressive disorder is 23.3%. So what's also interesting and important is that if we're only treating the patient with IBS for their medical symptoms, there's a whole nother aspect of their quality of life that can go untreated. And while many of these symptoms will improve as their IBS symptoms improve, it's still very important to screen patients for mood symptoms and check in with them on whether they're receiving adequate care. For both anxiety and depression, our patients with IBS were at 3 times more likely odds compared to a normal healthy subject control to have anxiety and depression. So that's a pretty remarkable statistic and number that we want to keep in mind when we're working with these patients. And also, I know there's a lot of dietitians that will be following along with this webinar today. So I really want to encourage you to, and gastroenterologists as well, not feel like you have to be the one that treats the anxiety and depression. But if they've never come across a psychologist or they're not receiving any mental health care, you can play a very important role in just screening for these symptoms and validating the experience of anxiety and depression with digestive disorders, and then really helping to kind of guide them in the direction of getting the right care. And more patients are kind of aware that there are mental health care interventions that are available in the digestive disorders sphere. In 2017, we kind of launched this terminology of psychogastroenterology, and Dr. Lori Kiefer and colleagues put out a best practices guide in the journal Gastroenterology in 2018. And if you've not read this article, please do. It's filled with clinical pearls. It's filled with language and terminology to help your patients understand better the brain and the gut and the role of that pathway and different ways in which our gut microbiota impact our mood. And so this article is excellent. And this table is just a snippet of some really great practice advice. And so just a very brief description of what psychogastroenterology is. It's really kind of a field. So similarly to gastroenterology or endocrinology or otolaryngology, psychogastroenterology is a field by which we practice the implementation of brain-gut psychotherapies. And now we really incorporate it into routine GI care. There was a time kind of earlier in my career and even before I got into this game, that going to see a psychologist was kind of the last ditch effort. A gastroenterologist or a primary care physician would do the best that they could with somebody with some of these difficult to treat digestive disorders. And then they'd kind of say, all right, I kind of throw my hands up, you should go see a psychologist. And oftentimes patients feel dismissed when it's explained and described in that way. And so this article really gives some excellent opportunities to describe work with a psychologist as part of routine care, as not last-ditch effort, that actually some of our research shows that it should be introduced into treatment plans early, and may even be able to mitigate some of the use of medications that sometimes can just be a Band-Aid for patients' symptoms. So as I've already alluded to, and as every single one of you that works with GI patients knows, that treatment can be complex, and it is incredibly important, especially with an IBS patient, to reassure them that their diagnosis is correct. At the University of Michigan, as a tertiary care center, we oftentimes are seeing patients that have seen 3 or 4 or 6 gastroenterologists and have had sometimes hundreds of thousands of dollars in workups. And it keeps coming back that they have diarrhea, abdominal pain, constipation, and essentially a diagnosis of IBS. But sometimes providers are not direct by telling the patient, you have IBS, and this is the treatment plan that we have in place for you. So ensuring a patient that their diagnosis is correct, that no additional workup is necessary, and that you have a confident treatment plan that might include ongoing work with their gastroenterologist, work with a dietitian, and work with a GI psychologist. This provides patients with a tremendous amount of hope. And if you've been a patient and you have had multiple workups and have not gotten better and continue to have really embarrassing, painful symptoms, having hope goes a long way in starting kind of down a pathway of making change. So I cannot stress enough for providers at whatever kind of stage you're at that definitive diagnosis is so important for our patients. So this recently was an article that my group published where we were really trying to provide kind of community providers as well as people that might not have as good of access to a GI psychologist as some people around the country, with a care pathway of which patients should go to a GI psychologist for kind of psychogastroenterology treatment versus which patients might fare better with a general psychologist versus kind of comprehensive psychiatric services and medication management. So connecting patients with the proper treatment is, again, one of those things that if we can do it sooner rather than later, it saves patients a significant amount of burden. And we found, looking at a cohort of patients that had completed treatment at our institution for GI behavioral health, we looked back at those that did the best. And we found that those patients in our psychogastroenterology program with severe bowel symptoms that had a health-specific quality of life significantly impacted by their GI symptoms, a high brief symptom inventory score, good insight, and motivation to improve, those were the best patients for our treatment. Those that had more mild bowel symptoms and a high functional status, meaning that they're operating pretty well in their general day-to-day, a low brief symptom inventory score, but also recognized that general stressors such as relationships, work, school, those were the things that were more so impacting their quality of life. Those patients would likely do very well with a general psychologist who may also provide some health-specific interventions. And then those patients with more severe psychiatric comorbidities typically required more comprehensive psychiatric services that may include working with a psychiatrist for medication management, as well as potentially working with psychologists. So just briefly, again, because I know that I've got a lot of dietitians in the crowd and also gastroenterologists, I just want to give a little bit of plug for some newer research that's coming out on disordered eating and GI disorders. We really have to be aware of this and recognize kind of the role of disordered eating versus eating disorders. So some research in 2015 came out that showed that 23.4% of patients with GI disease displayed disordered eating patterns. And this can mean that they're following a restrictive diet, they're skipping meals, they're limiting foods. And so we want to carefully assess for that, and recognizing that there is this significant overlap between this disordered eating pattern and GI symptoms. It's important to, again, be aware, to screen, and then have proper resources for these patients. And when we think about some specific GI disorders where diet is so closely tied to their improvement, such as in celiac disease, where it's necessary to follow a lifelong strict gluten-free diet, we want to also be watching for if that's becoming more disordered eating or even leading to eating disorders. Then we have kind of the IBS-IBD population where, again, there are some restrictive diets that can help in maintaining and improving GI symptoms, but it can also be seen that patients become so focused on that restrictive diet that it can then lend itself to some more disordered eating or eating disorders. And so we want to be very aware of the complexity of eating disorders in this patient population, and also recognizing that there's this prevalence that on the uptake that eating disorders are kind of evolving and increasing to a prevalence of about 13%. In our GI clinic, two of the most common eating disorders that really gastroenterologists, dietitians, and psychologists should be aware of is orthorexia and avoidant restrictive food intake disorder, or ARFID. And briefly, orthorexia is kind of characterized by this obsessive focus on healthy eating. And weight loss might occur because of this, but it's not the primary goal. Whereas with other more traditional, well-known eating disorders, such as bulimia or orthorexia, body dysmorphia and body image disturbance are far more common in those and can drive the eating disorder. And the same thing with avoidant restrictive food intake disorder. These are patients that begin to restrict and limit their ability to reintroduce food because they are so afraid of symptoms coming back, particularly those GI symptoms that they were able to control by following a restrictive diet. So one of the studies that was recently done by Dr. Kimberly Harar in our group was looking at really just a study to assess the population of ARFID And this was the first large prospective study screening adult gastroenterology patients for ARFID. And again, a staggering number, 19.6% of patients in our outpatient clinic screened positive on the 9-item ARFID screen. And we also found that IBS patients were 2 times as likely to screen positive compared to non-IBS. So I think we're going to be seeing more and more information about ARFID. It's still a little messy in terms of diagnosis, but it's something that surely indicates that ARFID is likely under-recognized among our adult GI population, and certainly a target when it comes to GI behavioral health services. So briefly, we do, while BMI is just a kind of objective number that we can look at, and there's a lot of subjective factors that go into BMI, it's important to recognize that in my outpatient clinic, for patients that are severely underweight, they're not good candidates for cognitive behavioral therapy in the outpatient setting. And these patients require inpatient medical stabilization or intensive outpatient eating disorder treatment with eating disorder specialists. And so I just like to recognize that we need to be aware, we want to screen, we want to make sure that these patients are getting care, but sometimes patients with eating disorders are going to show up in our GI clinics much before they're going to show up in a psychologist's office. So many of you are probably very familiar with the low FODMAP diet and perhaps a little less familiar with gut-directed hypnosis. And so I'm going to tell you a little bit more about that in a couple slides. But what's very interesting is this study was done that looked at a randomized control trial that looked at applying hypnosis versus diet and hypnosis. And the IBS quality of life improvement scores really went across the board. So all groups that had either hypnosis or diet or both, those improved. But what we found was that hypnotherapy was superior in terms of improving psychological indices that included anxiety and depression. And so particularly for patients with any history of eating disorder or any suspicion that they may be experiencing disordered eating or symptoms of ARFID or orthorexia, if you have access to a provider that can deliver gut-directed hypnosis, this is probably a better treatment option for that patient, given that it takes the focus completely off of restrictive diet and eating practices, but also produces modifiable and significant improvements in their GI symptoms. So when we're thinking about a multidisciplinary approach for patients with digestive disorders, it's certainly a gastroenterologist or a primary care physician that can do the initial medical workups to ensure that diagnosis. A patient may work with a nutrition specialist, a psychologist, and again, some patients may require working with a psychiatrist who can also provide some insight from a neuromodulator perspective, which can be very helpful in these patients. So we very frequently have patients that are taking medications that work on that brain-gut dysregulation pathway that can produce, that utilize SSRIs, SNRIs, and tricyclic antidepressants. But I'm going to kind of veer into talking about some of our behavioral health interventions. But building rapport is extremely important with this patient population. And that's always where I start. And as I introduce some of our behavioral health interventions, this picture here of our GI stress cycle is one that certainly delivers a lot of buy-in from patients because they feel so understood when we go through this. So I always start with that initial GI discomfort, and the patient will talk about their GI symptoms. And they almost always begin to then describe this unhelpful thought pattern. Here we go again. Oh my gosh, this is so painful. I can't believe I have to get to class or I have to get to work, and here are my GI symptoms again. So those anxious, depressive types of thoughts begin to drive that emotion of anxiety, frustration, and anger. And when this happens, we then begin to have sympathetic arousal. And this again is where kind of the stress and the gut begin to connect and leads to worsening symptoms. So being able to provide patient with a picture of what they're feeling both emotionally and physically is certainly something that they appreciate and are oftentimes shaking their head up and down saying, how did you know this is me? This is what I experience on a day-to-day basis. So from there, I then might provide the patient with some psychoeducation around kind of why stress is so impactful on the gut. And briefly defined, stress is an acute threat to our body's homeostasis. And it shows both short and long-term effects on the functions of our gastrointestinal tract through that sympathetic activation. So we can have urgency, cramping, spasming, diarrhea, constipation, nausea, vomiting, GERD symptoms, all due to the serotonin receptors and the corticotropin releasing hormone that happens in our digestive system. So right there in our stomach and our gut. So then becoming aware of stressful triggers can then also contribute to this neuroendocrine response, which produces these noticeable gastrointestinal effects. So stress really does matter. And this does not mean, though, that we're going to take all stress away. But we want patients to recognize that untreated stress can be a contributor to their gastrointestinal physiology and presentation. So running through some of those can be alterations in gastrointestinal motility, increases in visceral perception, so the brain scanning for those nerves. And so this is why I'll tell a patient, you know, when you have something to eat and you begin to go through the digestive process, the normal digestive process is far more uncomfortable to patients with GI problems because they actually are feeling the physical effects of digestion related to that visceral perception. And so in addition, stress can cause changes in our gastrointestinal secretions, increases our intestinal permeability, and then also can impact our microbiota and mucosal blood flow. All of this leads to some of these more common diagnoses. So in addition, just as stress is impactful for patients with irritable bowel syndrome, it's that much more impactful on inflammatory bowel disease because it can lead to worsened inflammation and ulceration in the gut. Also, it can create in some people, food antigen related adverse response, peptic ulcers, and again, those GERD symptoms of regurgitation, heartburn, and chest discomfort. So this is going to be kind of the meat of cognitive behavioral therapy and considering which patients to send to a GI psychologist. So when a patient is considering working with a GI psychologist or a mental health provider, they have to be invested and recognize that this is not the kind of therapy where they show up at the therapist's office, they talk, the therapist listens, and they come back next week. CBT, or cognitive behavioral therapy, is a very interactive type of psychological intervention, and it's commonly used in medical settings to address anxiety or depression that's related to medical symptoms. And so for patients with that are interested and have insight into the role that, yes, stress impacts my gut, they can really be good patients to consider for CBT. However, untreated mental health disorders really should be prioritized and managed first. So kind of going back to when we were thinking about appropriate patients, using that model that I showed you with psychogastroenterology, general mental health, and psychiatry, if patients have untreated, more severe anxiety or depression that really takes precedence over anything else in their health, we want to make sure that those patients are working with a more general mental health provider to stabilize their mood symptoms first. We also want patients that are coming to see a GI psychologist to recognize that change is not going to happen immediately. And so recognizing that while in the scheme of mental health care, our interventions tend to be quite short-term, ranging from 5 to 7 sessions. It's going to take some time to notice improvements in their GI symptoms for most people. And insight is really key. So if a patient has low insight or low motivation to address their symptoms from a behavioral health perspective, then you probably shouldn't waste anybody's time by referring them to a psychologist. So some of the factors that go into CBT for digestive disorders are psychoeducation, and I've been giving some tidbits about language that we can use, about the brain-gut axis and the physiological responses to stress, to help patients have that buy-in and that understanding into why their treatment should be multi-dimensional with their work with gastroenterologists, dietitians, and psychologists. So psychoeducation is very important in terms of CBT and learning about their diagnosis. Relaxation strategies are my most commonly utilized strategies to really help patients learn how to calm down that sympathetic arousal that happens between the brain and the gut. Diaphragmatic breathing, guided imagery, muscle relaxation strategies, gut-directed hypnosis are all types of interventions that fall into this category. Then there's cognitive restructuring. And this is where we help patients to learn more accurate cognitive responses to their stress and symptoms. So commonly patients will catastrophize about their symptoms. And so if I were to say, you know, we'll just stop thinking that way to a patient, that would be very kind of not instilling hope, certainly. And so we want to give patients these cognitive restructuring interventions that we teach them in session to help them recognize when they are catastrophizing or having GI-specific anxiety and modify that thinking. Problem solving is also a big one, where we teach patients emotion-focused coping for uncontrollable stressors. So an example of emotion-focused coping would be relying on social support, using cognitive restructuring so that their thoughts are more constructive, and also relaxation-based interventions. All of this is to help patients have more flexible coping strategies. And then also exposure techniques. So oftentimes patients learn how to avoid certain situations because they have a great deal of fear about the possibility of their symptoms presenting. And so we want to make sure that we're teaching patients how to face those fears and expose themselves to some of the things that they've been avoiding, such as maybe riding public transportation, certain foods, or avoiding travel altogether. So diaphragmatic breathing, very briefly, I've given you access to a YouTube demonstration of me providing you with instruction on using diaphragmatic breathing. This is an intervention that I teach everybody that I work with. This is a picture of me leading an entire audience at a very recent Crohn's and Colitis Foundation patient update on diaphragmatic breathing. So here you go. Here's a relaxation intervention for everybody, and I hope that you will share it with your patients, but also practice it yourself. This is something that I find myself doing quite frequently, again, to kind of calm down the gut, but also to mitigate stress. So some types of GI-specific anxiety that we can target with CBT is that visceral anxiety, where patients experience fear, worry, or hypervigilance. in the face of GI sensations or GI symptoms. There's also pain catastrophizing, where there's a focus and an exaggeration of the threat from pain, or a tendency to predict that this pain will lead to a negative episode or flare-up of symptoms. And then there's catastrophizing, where I'm sure you all could come up with some anxiety or some language of patients that you've heard, such as, I would die if I had a bowel accident in public, or I could not possibly go to work or to school feeling this way. And so oftentimes CBT helps patients learn and challenge these belief systems. And this is an example of a Cbt Thought Record, where, again, this is an intervention that I teach to patients to help them begin to observe how they're thinking and modify that thinking to come up with alternative ways that help to decrease their anxiety and the role in which that anxiety plays on their symptoms. So considerations for gut-directed hypnotherapy. At this stage, if I were with you all in a room, I would be having you raise your hand if you had ever heard of gut-directed hypnosis. Hopefully, as more and more literature becomes available about psychogastroenterology, this will not be so taboo or considered that it's there's still some stigma, certainly, when we bring up the word hypnosis. But what I love about this intervention is that there is now a significant body of research that supports utilizing hypnosis for patients with IBS. Also, to use it with patients with upper GI symptoms such as GERD, functional heartburn, dysphagia, globus. So there's a significant body of research that supports this. It's evidence-based, and it really gets at targets for that brain-gut dysregulation. Also, and we're doing more and more work, but we have been able to show that hypnotherapy can induce changes in pain-related brain activation when we look at PET scans. So being able to recognize and show patients that this gut-directed hypnosis protocol, which is safe, it's effective, especially for patients that have failed other types of treatment, that it improves the extraintestinal symptoms in both patients with IBS and IBD, and it reduces patients' need for medication. That this intervention actually changes the way our brain is functioning based on PET scans. It really is attractive to patients. Now, certainly there are some limitations. This journal article and recent review that was just published in 2019 talks about the Manchester protocol. So it's typically a 12-session protocol. In my practice, I most frequently utilize the North Carolina protocol that was written by Dr. Ollie Paulson. And it's a 7-session protocol that can be modified a bit to shorten if the patient is experiencing significant improvements early on. So there are limitations that are listed here for both protocols, but patients tend to find that it is a enjoyable intervention to learn. They find that it's nothing like stage hypnosis where a bell goes off and they cluck like a chicken. So typically after the first session, a lot of the stigma and hesitancy about using hypnotherapy for their medical symptoms goes away, because they learn also how deeply relaxed their body is. And the thing about our gastrointestinal patients is that many of them are carrying around a significant amount of physical stress. And much of that is driven by the brain-gut dysregulation and kind of the role of the brain-gut axis. And so when these patients are learning in behavioral therapy how to better relax their body, and that there are actual techniques that can teach them that, it's so rewarding as a psychologist to go through a gut-directed relaxation intervention and have a patient say, wow, I had no idea my body was carrying so much tension. Many of the kind of common feedbacks that I get after a session are that it feels like my body just had a massage, and that they are remarkably surprised at, after one session, how through doing these interventions, their gut relaxed. And so in a similar way with diaphragmatic breathing, the gut is relaxing and it's producing some of these improvements in serotonin function based on, again, that brain gut regulation and dysregulation that can happen in our patients with gastrointestinal issues. So as I near the end here, really what our patients need in many cases is a multidisciplinary treatment plan. And a couple of my goals is to help patients understand their diagnosis and their treatment plan, to recognize that there is appropriate support to carry out treatment recommendations available, and if not, to help kind of troubleshoot and find the right providers. So if they don't have access to a GI psychologist, I have a couple recommendations. I think the availability of dietitians skilled in working with GI patients is improving remarkably as well, and patients have more and more access to GI dietitians. And even meal plan services like Epicured. So I think that if there was ever a good time to be a GI patient, I guess now is the time, because we really have more options to offer to patients, and we want to improve their symptoms. And most importantly, we want them to gain the ability to implement these behavioral changes that are sustainable over time, and that they're not following overly restrictive treatment plans for too long, because it's not sustainable. So many of the stress management and relaxation-based interventions that I teach patients, I want them to continue to use them. And I really introduce it as, yes, in the short term, it's hopefully going to improve your symptoms, but stress management is important for our overall health in the long run. And so even though patients are experiencing significant improvements in their digestive disorders and diseases, many find that they continue to implement the stress management skills long after their treatment with me has concluded. So this is a new therapist finder option through www.romegipsych.org, where you can put in your location and determine whether there is a gastropsych provider near you. This is something that just rolled out in the last year, and we're very excited about it. Our number of providers around the country will improve with time. So right now there still is some limitation, but in most major metropolitan areas, or if you're near an academic health institution, there's likely a GI psych provider close to you. And then if not, these are some of the factors that I would look for in a general mental health provider that an IBS patient or a patient with digestive disorders may benefit from. So those that specialize in anxiety or health behaviors, providers that specialize in cognitive behavioral therapy, those that are familiar with the brain-gut function and interaction. And you can always ask mental health providers these specific questions. Do you have interest in working with patients with digestive disorders? And as providers, so as a dietitian or a gastroenterologist, primary care, I always recommend doing a little bit of a search yourself in your area so that you may have an established pathway for patients so that they don't have to do some of this legwork. So in summary, chronic digestive diseases are difficult to treat and often require comprehensive treatment plans. And I hope that more and more patients will consider psychogastroenterology as a part of their treatment, and that brain-gut therapies are evidence-based interventions. We do not want to consider them as a last-ditch effort. We really want to introduce them early and often, because of the way in which these interventions can target brain-gut dysregulation, as well as addressing the mood symptoms that are certainly comorbid with many of our digestive disorders. And patients are also very open to working with a GI psychologist if you deliver working with a psychologist in the right way. So making patients feel as though a psychologist is a part of their treatment plan in addition to continuing work with their gastroenterologist or their primary care physician. Patients really appreciate this multidisciplinary approach. So at this point, I am happy to take some questions and we can go from there.
Thanks so much, Megan. And indeed, we did get a couple questions as you've been talking. Just as a reminder, guys, if you hover over the screen, you can see Q&A button on the bottom, and that's where you can put your question through. So our first question is, do patients need to be referred by a gastroenterologist to receive gut-directed hypnotherapy?
So my recommendation for this is that if you have received a diagnosis that's definitive, so you have had a colonoscopy or you're very confident in your diagnosis by a medical provider, then I would say that you could, if you know of a mental health provider that specializes in gut-directed hypnotherapy, then you could go right for that. So a GI doc doesn't have to. At my academic institution, patients can't self-refer in. They are referred by their gastroenterologist after they've had their extensive medical workup.
Okay. Okay. Couple other questions. Is there any evidence to support neurofeedback or biofeedback?
So there is, and it can be very helpful. Again, finding providers that specifically do neurobiofeedback for GI, there are some limitations. So I wouldn't say that if you can't find somebody that does biofeedback, that I would really look into providers that specialize in relaxation training, because in a lot of ways you can get at the same targets of brain-gut dysregulation and learning how to kind of decatastrophize your emotional response to physical sensations in the gut. That can be really helpful. Even apps out there, there are 2 apps that can teach diaphragmatic breathing that in a way kind of serve as your own home biofeedback, because essentially what biofeedback is, it's learning how symptoms in your body translate to kind of emotional symptoms and how you can regulate your breathing to decrease those sensations. So Breathe to Relax is a good app. And then there's also Belly Biofeedback. And I have no connection to either one of those apps. I just recommend them to my own patients.
Okay, perfect. And is it possible for a GI psychologist to meet with someone over the phone and have, in case there's not a GI focused psychologist in a patient's local area?
Yes. So this is also a growing area of both research and in our field, where we're finding that services delivered via Skype or teletherapy are just as effective for many patients with IBS. It's always important to have proper diagnosis. And so before you work with somebody via teletherapy, oftentimes they'll require some kind of definitive diagnosis. But yes, the research is very promising, moving toward disseminating care in that manner.
Okay, perfect. We just have one more for you, Dr. Real. So one question, so you spoke a lot about the ways that stress and traumas affect GI systems, but not as much about the ways the gut inflammation can impact the development of anxiety and depression. Do you address this with patients, or have you seen the low FODMAP diet or anti-inflammatory practices actually reduce anxiety and depression in patients?
So I could talk a long time about this. So I guess my fastest answer would be yes. But what we want to be careful to do, especially for patients with IBD, is recognize that a lot of our treatments are complementary. And so we know that in the low FODMAP diet and gut-directed hypnosis, that we can reduce symptoms of anxiety and depression through particularly the behavioral interventions, not so much diet, in patients with IBS and IBD. But especially in patients with IBD, we do not want you getting off of your medications that are also controlling inflammation, because you're having improvement in anxiety and depression and some of these other symptoms. So I just, that's a caveat to a much longer conversation. But yes, by treating the inflammation, we are very likely to see reductions in anxiety and depression.
Wonderful. Well, thank you so much, Megan, for your time this evening. I know it was very personally informative and interesting to me, and I hope it was for our audience as well. So thank you all for attending this evening. Please stay tuned for opportunities to join us again. We are so grateful to play this role and bring together this digestive health community.
Thank you so much for having me. Have a great night, everybody.
You too. Bye, everybody.